So, first of all, let me ask you, the Prostate Cancer Observatory, what exactly is it about and why are you involved, Karim?
Yes, so the Prostate Cancer Observatory is championed by a collaboration between the European School of Oncology and the European Association of Urology, the EAU. And the purpose of this meeting is to get together all the disciplines that are working on prostate cancer. And every year, these experts can give us in 5 minutes their idea of what is happening, what are the latest discoveries in prostate cancer from their perspective, and how do they see that developing in the course of the next year.
And what was the latest innovation that was most interesting for you heard about today?
Gosh, there were so many. I think it's hard to look at all of these expert opinions in separations because they are all tied together. Amongst the most relevant elements, we have seen latest discoveries in molecular imaging of prostate cancer, particularly PSMA-based, and the impact of the discovery of things we didn't see before, and we used our clinical parameters for decision making. Now, with the molecular imaging, we are seeing new foci of cancer, and the impact of that, how it's going to change our management of the disease, I think it looks like one of the most revolutionary approaches to prostate cancer.
Do you agree with that?
I would tend to agree. I think that one of the major advances in prostate cancer during the last years, but in particular also 2015, is the fact that we are now able to do molecular profiling of tumors. Of course, this is not standard of care. It's not implemented in each and every institution because it's very costly. But it will help us to decide that patients have different diseases either within their own body, so there's heterogeneity in the tumor, but also between patients. And I think that all these technologies will ultimately result in a much better individualized treatment for patients, because now we're treating patients as if they all have the same disease and as if it all needs the same treatment answer. And that will definitely change over the next 12 months, but for sure within 2 to 3 years.
I think what the theme of what we're taking home from this session like today is probably shying away from comparison of effectiveness of therapies, because with that there is the assumption that the patients and the cancer are pretty much the same. And I think what Professor Osanto is saying is that if we go from the outside manifestation of the cancer and we go inside the cells, inside the nucleus, we find that these cancers are different. The drivers, the engine, the mutations that are driving the behavior of this cancer are different, and even within the same patients and within the same cancer, there are different drivers. So the idea is now to go, instead of going from the outside and treating, is to go from the inside and formulate the treatments. With the molecular imaging, it opens a new field of applying surgery, which is the surgery targeted to these metastatic sites that often were not discovered or were not known before. So the role of surgery in the management of prostate cancer is shifting, is adapting to the knowledge, but is also increasing tremendously.
Professor Osanto, is there anything you would like to add to this from a medical oncologist's perspective?
Yeah, I think that we should do our utmost and make sure that we have the money, that we can use money to have much more research tests that are now done in the research laboratories, implemented in our daily care for prostate cancer patients, because there is this heterogeneity. I think also the primary tumor, there are modalities which you can combine at this moment and which will be helpful to decide whether a patient needs only radical prostatectomy or radical prostatectomy plus radiotherapy or one of these more localized treatment options together in combination with specific drugs. We really have to think in a much broader way and develop a view in which we are able as clinicians to use all the techniques that are now available. For instance, one of the important findings of 2014-2015 was the fact that we have these ARV7 splice variants that we can detect in circulating tumor cells in prostate cancer patients. And that would be relatively simple to implement, but it's already something which is a hurdle for us to implement. I do think we have to speed up matters in order to save every patient that is coming today, tomorrow, and the day after tomorrow.
It was great talking to you both. Thank you so much for
pleasure.
joining me.